مساء الخير ونشكر المنظمين على كل حاجة. ولو تلاحظوا الميكروفونات كلها عليها ألوان كده. أنا هقدم الموضوع اللي قدامكم ده على lymphedema after treatment of breast cancer screening and risk factors اللي هيتكلم الدكتور بروفيسور ألفونس تاغيان. هقول عنه حبة صغيرة، كنت أحب يبقى عندي تفاصيل أكتر لكن ده اللي أنا عارفاه. هو خريج اسكندرية عشان كده أنا بتكلم عنه. وفي وقت من الأوقات كنا بنشتغل مع جوستاف روسي، كان عندهم طلبة وكانوا بيجوا، فرئيس القسم هناك الدكتور دانيال شاساني قال إنهم عندهم واحد من اسكندرية ممتاز جدا اسمه ألفونس تاغيان. كنت شفته بقى، بعدين اختفت سيرته خالص، بعدين لقيته بيظهر بقى في المؤتمرات وبيقدم input very good input، واستعداده للتفاهم والتعاون is very good، واحنا نفخر بيه ان هو خريج اسكندرية وانه دلوقتي في هارفارد ميديكال سكول في اعلى المراكز. اهلا بيك يا دكتور ألفونس.
اهلا بيك، شكرا جزيلا.
اتقابلنا السنة اللي فاتت في اسكندرية برضو، كان معنا سامي البدوي.
صح يا
اهلا بيك، كلنا اذان. اتفضل.
Good afternoon, everybody. مساء الخير. My name is Alphonse Taghian. I'm talking to you from Boston, and I would like to thank Dr. Abdeslam and his team for inviting me, and I would like to thank also Dr. Laila Musa for the introduction. So I'm going to talk about lymphedema today and how do we approach this problem. So you might think that lymphedema is just another complication from the treatment, but you would not imagine how much devastating lymphedema is to patients. And if you want to know, just ask the patient. Ask the patient, how do you feel about lymphedema? And I did that. It has ruined my life. I would almost rather I had died. And another one, I fear lymphedema more than recurrence. And I heard this from many patients. And here, this is a well-known actress and advocate for the lymphedema field. She said publicly, lymphedema was almost worse than having my breasts removed. She had bilateral mastectomy, and actually she was BRCA positive. I was bitter, I was depressed. I thought my career was over. There is no way, I'm done, everything is done. And here, it strangled the mobility and quality of life from my wife and consequently from me. So lymphedema impact also the whole family, not only the patient. And this is the list of complications which can happen from surgery, radiation, and chemotherapy. And lymphedema stands really very strongly for one thing. It is very obvious to everybody that this patient had breast cancer. The patient cannot socialize. Embarrassed to go to her daughter's wedding. It is a continuous reminder of breast cancer and of the struggle and anguish that patient and her family wanted to forget and heal mentally and emotionally from breast cancer. It is incurable at this stage. If we leave it at this stage, the game is over. And it has a devastating impact on the quality of life, the body image, and the upper extremity function. It could be prevented, and that's the whole point. If we are careful and we can catch it early, it could be prevented. And this is the different degrees of lymphedema. And the percentage here, the increase in swelling compared one arm to the other. So what we have today is basically an impairment model, which means that we wait until we see the problem. We see the lymphedema. It's already big if we see it. And then we refer the patient to physical therapist and goodbye. But what I would like to see is catching lymphedema very early at 11%, 7%, and some people even think at 3%. And this become a screening-based model. You cannot identify 7% here unless you measure it, unless you screen for it. You will not see it with your eyes. So that's what's happening today. today is impairment-based model. We want to switch it into screening-based model, and we started this few years ago. So what's the optimal technique to measure lymphedema? There are many techniques. The most simple one is just a tape, and you measure the tape at certain points here, circumference. Maybe you could just have 4 different points. You could put this in the software, the truncated cone formula, to transform the circumference into a volume, and that's what we need to do. Here, water displacement, not very much used now. It has some hygienic issues, and the parameter, that's what we use, a very accurate, it's just a laser, which the frame comes in and out, and then the volume of the arm, it shows up on your screen. And there is bioimpedance measurements. It's like the EKG. It reflects the ability of electrical current to pass through the limb. Is it necessary to have a baseline measurements? Absolutely, because we found in a study that almost 30% of the patients, they have asymmetry in their arms before any treatment, just as the diagnosis with a biopsy. And from those 28.3%, 3%, the asymmetry is very big. It's 10% difference between both arms. Now, the definition of lymphedema is 10%. If you don't have this information up front, you will overdiagnose or underdiagnose patients. And assessing the degree of lymphedema really should take on consideration the baseline. And the uncertainty about not having a baseline and considering the post-operative measurements as the baseline will underdiagnose or overdiagnose 40 to 60% of the patient. So we cannot screen without baseline. And if we miss the baseline, all what is left for you is to wait until the patient becomes symptomatic, or you could see the lymphedema yourself. It's already 10 or 15%. Baseline measurements is absolutely necessary to do a good screening for the patient. How do we quantify lymphedema? We integrate the baseline into the measurements of the day. And this seems to be like a complicated equation. It's really is not. It's a relative volume change. We call it this way. And that's the affected arm of the day of the measurements. And this is the affected arm at baseline. And the unaffected baseline is here. And this is vice versa, -1. And you will have a percentage relative volume change. So we had a formula for unilateral breast cancer and the other one for the contralateral to take the weight adjusted change. How do we define lymphedema? Well, there are many definitions of lymphedema, and this is a big problem because people don't speak the same language. Different groups will have different definitions. So the very old definition is a circumference change of more than 2 centimeters at 1 or 2 points, absolute circumference, or absolute volume change, or absolute volume difference more than 10%. So anything that is absolute, in my opinion, is very wrong, and I will show you why. We use the relative volume change. So we use volumetric difference, and we use it relative, taking in consideration the baseline. So why is that? And it's very simply, suppose you look at this arm. It's not a large arm, it's thin arm, and you have a circumference increase by 1.5 centimeter. 1.5 centimeter is not considered lymphedema. But this 1.5 centimeter or less than 200 ml might represent 10 to 15% increase in volume compared to the other arm. Now you go to the opposite here. This is a very large arm. Could be a difference in circumference by, let's say, 2.5 or 3 centimeters. So you cross the 2 centimeter and you will consider this patient as having lymphedema, but this increase in circumference, which is very minimal, or 220 ml, which cross the line for lymphedema, might present only 3.7 or 4%. So basically, if you wait until this patient reaches the 2 centimeter circumference, it's already 15% difference. And this is a really underdiagnosis, or you just missed it. And if you will consider this as a lymphedema with only 3 or 4% difference, you will consider this overdiagnosis, because this might not be significant for such a large arm like that. And I put this in a graph. So here is the arm volume. The larger the arm volume, that this absolute increase in 200 ml or 2 centimeter will represent a small relative arm volume change compared to a small arm like that. And so this is basically overdiagnosing and underdiagnosing patient. And we, based on all this, we wrote a sort of like a roadmap how to establish and sustain a prospective screening program. And expressing our experience. So in general, from a comprehensive meta-analysis, the incidence of lymphedema in general is 21%, and it is imperative that healthcare professionals caring for patients with breast cancer, that they should have knowledge about lymphedema in order to educate, diagnose, and refer patient appropriately. So what are the factors increasing the risk of lymphedema? There are 6 of them. We'll go over them. And there are 2 factors which decrease the risk of lymphedema. So let's start with the most important factor in increasing the risk is axillary lymph node dissection. And this is a study which was just published from my group a month ago in JCO. It included 1,800 patients, and they were followed every 6 months with baseline and using parameter, and we use the relative volume change as the method for lymphedema, and lymphedema was defined as more than 10% relative volume change. So lymph node dissection here had around 25 to 30%. So if you take lymph node dissection alone, at 5 years, 25% risk of lymphedema compared to sentinel lymph node, which was 8% risk of lymphedema, and this was highly significant. This is not the only study which shows that. Plenty of studies show that lymph node dissection has a higher risk of lymphedema. Some people will break this down into how many lymph nodes removed, and it's always around the 20 to 25%. And when you go less than that, it's around it's less than 5%. So lymph node dissection is the most important risk for lymphedema. What about the regional lymph node radiation? Well, we looked at this in around 1,500 patients, and we found that if you give radiation to the chest wall or you don't give radiation, the risk of lymphedema does not increase. So irradiating the breast does not increase the risk of lymphedema, but irradiating the regional lymph nodes increase the risk of lymphedema. So we have here, when you have lymph node dissection and you add to it regional lymph node radiation, the risk will go from like 18 to 23, 24%. If you go to the sentinel node and you add the regional lymph node radiation, the risk is still low, but just pay attention that the number of patients in this group was quite low because this study was published in 2013 and the Amaro study just came a year or 2 before that. And I wanted to know, when does lymphedema occur? What's the timetable of it? So we found that this is a cumulative hazard rate. So the risk of lymphedema goes up very steeply in the first 6 to 12 months. And if you have lymph node dissection or you have lymph node dissection plus regional lymph node radiation, it can continue a little into 12, 18 months. It goes higher with the regional lymph node, and then the risk goes with more time. And the regional lymph node radiation also goes with more time. But when you look at the sentinel lymph node or plus or minus radiation, it just goes up a little bit and then it flattens and then it goes down. So most lymphedema occur in the first 5 years. Now we see sometimes lymphedema occurring really beyond that, sometimes at 10 years or even more. First, it is rare. And my sense is that the reason for this lymphedema, when it occurs later, there is something which triggered it, like infection, like fracture, like an operation, or a shoulder replacement, or any other operation. So that's what triggered the lymphedema. But the lymphedema coming from the treatment per se occur within the first 4 to 5 years. Now there is something very important. I wanted to know the contribution of the regional lymph node radiation vis-a-vis the lymph node dissection. How much each treatment contributes to the risk of lymphedema. And we found something really fascinating. The main reason of lymphedema is actually the lymph node dissection. We in radiation oncology, we have this just bad reputation that we call lymphedema. When you compare the risk of lymphedema from lymph node dissection alone, 25%, and you add radiation to it, it goes up to 30%. This risk here is not significant. And when you look at the sentinel lymph node, it was 8%. You add regional lymph node radiation to it. The difference between the 8 and the 11% is not significant. But the difference between lymph node dissection and the sentinel lymph node was highly significant. And you look here in the multivariate analysis. When you compare lymph node dissection versus the sentinel lymph node plus regional lymph node radiation, which is the AMAROS, basically AMAROS study, the hazard ratio is 2.66, and this was highly significant. But when you compare lymph node dissection plus radiation versus lymph node dissection without radiation, still it adds to it. And I'm not saying that radiation does nothing. Radiation does something, but this was not significant. It adds just a little bit. This study was done on 1,800 patients. Now there is another idea which came up from one of our colleagues in Chicago. So this group of Gross and Jonathan Strauss identified women with stage 2 and 3. So that's advanced stage. And they assessed the regional nodal irradiation on 265. And the lymphedema outcome was prospectively recorded clinically. So this was not measuring with parameter or with volumetric, just clinically. And they divided the area here into 8 sub-regions. And they called it upper posterior, upper medial, with some anatomical boundaries in all of them. And look at this one in the middle. That's called axillary lateral thoracic vessel juncture, ALTJ, this one. And they did a multivariate analysis. And they found that actually, if the dose of radiation to this specific volume is less than 38 gray, the risk of lymphedema is much lower. It's around 6%. And if it is more than 38 gray, it's 37%. And this was in a multivariate analysis. It took with it the BMI and the number of lymph nodes removed. And in fact, you might say, okay, if I want to decrease my dose here to reduce the risk of lymphedema, maybe I'm reducing my dose to the whole regional lymph node area. This was not found. It's actually the V45 was really covered the 99% to 100% of level 1, 2, and 3 and the supraclav. That's by giving radiation maintained to this specific area into 38.6 gray. Now, this needs to be validated. And if it is validated, it will be very important for us actually to avoid giving higher dose of radiation to this area. And they call this organs at risk. So at some point in the future, if this is validated, what will happen is that when we will prepare a 3D planning, we will contour the heart, we will contour the lung, and beside all the levels of the lymph nodes, but we will have to contour this specific volume, and in order to avoid giving radiation more than 38 gray. So this is something to come in the future. Now, what about the weight fluctuation and the BMI? BMI was found to be significant risk. It's universal. It's in every paper. It's always significant risk. BMI more than 30 versus less than 25. This is the risk, and it's highly significant. And also one thing very interesting is weight fluctuation. While high BMI is a risk to develop lymphedema, so you are tempted to ask the patient to go on a diet, to exercise, to reduce her weight. But this weight fluctuation is like very counterintuitive. If the weight goes down or it goes up, the risk of lymphedema increases with it. This was found in 2 large studies, one from my group and one from Kathy Schmidt's group. Now, what about chemotherapy? Chemotherapy is not clear. Some data suggested that chemotherapy is associated with a higher risk of lymphedema, and other studies suggested that there is not any significant impact of the chemotherapy on the risk of lymphedema. And some people suggested actually that taxane might increase the risk of lymphedema. We looked at this, we did not find it associated with lymphedema. We found taxotere to be associated with moderate lymphedema, like an increase of 5 to 10%, and did not really progress into more than 10%. Some people suggested Herceptin is a risk. We did not look into this. What about cellulitis and seroma? It's actually a lot of people find that. Seroma here, also seroma. And we found in our study that cellulitis is a significant risk of lymphedema. Actually, some people found trauma also. And the issue with cellulitis is really very serious. Cellulitis induced lymphedema increase the risk of cellulitis, and you have a vicious circle. And I know patients who have been in and out the hospital for cellulitis for a long time, and actually they are maintained on antibiotics for life. Now, what about subclinical edema? So subclinical edema definition is basically an increase in arm volume from baseline that does not qualify as clinical lymphedema. It is not visible on clinical exam. And when you look at the volume, when you measure it, it does not go beyond 10%. So it's like either 3 to 5%, and we consider it 5 to 10%. So I wanted to know if this very mild swelling, does it really precede lymphedema so we can treat it at this stage? So we looked at 1,100 patients, and we had like a natural history. We followed the patient. We just kept following it and to see how the swelling goes up and down. So we found that in a multivariate analysis, that the risk of lymphedema came with a BMI at diagnosis, lymph node dissection, as well as the 5 to 10% relative volume change, whether it's early or immediately after surgery or late beyond the 3 months after surgery. So it is a risk in a multivariate analysis. So we looked at this data in a different paper, which included 1,790 patients, which is still in preparation. So we looked at patients who we wanted to quantify what percentage of patients actually move into 5 to 10%. So the lymph node dissection patients, 40% of patients moved into the 5 to 10%, but not all will move into more than 10%, only another 40%. When you look at the sentinel lymph node, it's 25% had a subclinical lymphedema, and only 11% moved into the full-blown lymphedema. And this is a cumulative frequency. Time zero here is a time that the patient had 5 to 10%. And you could see that almost 40 to 50% of the patient with the lymph node dissection moved into lymphedema. Maybe there is something to do here. And I think we are preparing a randomized trial for this specific population who had 5 to 10% randomized between treatment and no treatment. So now what about factor decreasing the risk of lymphedema? And the thing which really surprised me, we're looking at reconstruction and lymphedema. And this is a study on 600 patients. 65% had immediate implant, 11% had immediate autologous, and 24% had no reconstruction. No reconstruction in a univariate analysis had 26% risk, 2-year cumulative incidence of lymphedema. While the immediate reconstruction was 5%, and when you break it down, implant was 4% and autologous was 9%. So we did a multivariate analysis. We found that BMI, lymph node dissection, number of lymph node dissected, all of them were a significant risk with a hazard ratio higher than 1 for lymphedema. But implant or immediate implant, the hazard ratio was 0.35. So if you do an immediate reconstruction, your risk of lymphedema is cut by 2/3, and this was highly significant. But we found that there was a difference between no reconstruction and the implant reconstruction, but the autologous reconstruction in this cohort was not significant than no reconstruction. But we know that this is because the number of patients with autologous is quite small, like Mass General is always, like the great majority of reconstruction is based on implant reconstruction. So I looked at this and I was surprised that reconstruction actually has some protective effect for lymphedema. And I wanted to double check that with an update of the study. So we moved up into 1,000 patients, and by now we might have 11 or 1,200 patients. We found exactly the same. No reconstructions, the highest risk of lymphedema. But we found that autologous and a single stage implant and expander implant, all of them were together a decreased risk of lymphedema, exactly the same with a hazard ratio of 0.32. So I looked at the literature and to try to find whether other people found that. I found that Memorial Sloan Kettering found the same thing, but the way how they measured lymphedema was all the way like circumference, 2 centimeters. MD Anderson had a paper, the odd ratios was 0.37, exactly like us. And South Korea had the same thing, 0.46, but the way how they measured lymphedema was different. So those are the 2 papers from my group, and usually it confirmed each other. I saw a meta-analysis recently, 2 years ago, which concluded that breast reconstruction was correlated with significantly lower odds for lymphedema, and there was no statistical significant difference found between the implant-based and the autologous reconstruction. How can we explain that? Well, there are a few ways of explaining it. When you do a skin-sparing mastectomy, you basically don't cut the skin that when you usually do with a no reconstruction, just flat chest after that. You have to cut a lot of skin when you have no reconstruction. But when you have immediate reconstruction, you do skin-sparing mastectomy or nipple-sparing mastectomy, you basically preserve the lymphatic channels under the skin. While patients with no reconstruction, they have more skin resected. And the same author also they gave another explanation. When there is no reconstruction, there is more adhesion, more fibrosis, and obstruction of the lymphatic flow. With both explanations actually are very plausible. There is another one when you do tissue expansion and capsular contracture. There is tissue ischemia, which increases the expression of VEGF and stimulates the tissue angiogenesis and the lymphatic regeneration. That's another explanation. But the data here, I think, is solid. So what's the second way of reducing the risk of lymphedema? So the first one was to do immediate breast reconstruction. And the second one is to avoid lymph node dissection when you have 1 or 2 positive sentinel nodes. And this is based, this is either in mastectomy or lumpectomy. And this is based on basically the Amaro study or the Z11 study that all of us know. So I come back to the same study and graph. So here we see the difference, like if you avoid lymph node dissection and you just give regional lymph node radiation with positive sentinel node, you reduce your risk of lymphedema by 2/3, from 30% to 10%. While doing that, you maintain the same local regional recurrence. So it's basically the axilla is well controlled without doing the lymph node dissection. So in conclusion, how can we reduce the risk of breast cancer-related lymphedema? Number 1, screening for early detection and intervention. Number 2, you identify the high-risk patient, like lymph node dissection, high BMI, no immediate reconstruction, early volume swelling, and cellulitis. You counsel them, and you put them under your close observation. You talk to them, and you tell them anytime you feel your arm is a little bit heavier, or the ring in your finger is getting tighter. There are a lot of clues like that. the patient should check. And because the treatment is quite simple, you just put sleeve, but the sleeve will work when you have a 5 to 10% or 10 to 15% relative volume change. But the sleeve will be just palliative once you have the 20% and the 25% relative volume change. Early detection is very important, and baseline measurement is very important. And avoid lymph node dissection in patients with 1 to 2 positive sentinel node. Probably you just like this is a collaboration between the surgeon and the radiation oncologist. My surgeons just don't like to do lymph node dissection anymore. Sometimes it scares me because it's not only 1 or 2 positive sentinel nodes, like 3 positive sentinel nodes, sometimes more. It just, we really believe that the lymph node dissection is the main risk factor for lymphedema. And thank you for your attention.